Welcome back. My next guest is Dr. Graysen Petersen Fitz, who is an orthopedic surgeon with Bluegrass Orthopedics. Welcome.
Thanks for having me, Dr. Fox.
Now, I mentioned back pain, and they might have a herniated disc. Some people call it a slip disc. Let's start out with what in the world is a disc to start with?
Sure, that's a good question. Our spine is made up of a column of vertebral bodies and discs. They're the bones and the discs between them that support them, all right? The discs provide support, they provide function, they provide mobility. Now, when we're all born, all those discs have a lot of water content and they're nice and pliable. As we get a little bit older, some of that water drains out and they get a little bit stiffer and they can start to cause us problems.
And when you mention problems, sometimes they use the term herniate. Maybe explain that to us.
Sure, there's two sort of parts of a disc, and there's a soft inner portion and there's a firm outer portion. When we talk about a disc herniating, some of that inner portion kind of pushes out through and it can impinge upon a nerve or irritate a nerve. It can cause a lot of things like neck pain, back pain, arm pain, or leg pain.
So are there certain risks for a disc herniation? I mean, who might or why might that occur?
Sure, absolutely. I think you can lump these together as both modifiable and non-modifiable risk factors, meaning there are some things we can do to mitigate that risk. Things like being mindful of our posture and making sure that we lift things with good form. You never want to bend over at the waist and pull something up quickly. Try to bend at the knees, things like that. Maintaining a healthy weight helps. And avoiding smoking. We've actually found over years that smoking is a very modifiable risk factor that's tied pretty closely to the risk of a disc herniation.
Age plays a process there. You said young, you're pliable. I'm not so pliable anymore. Am I at more risk?
In a way, yes, but the pathology changes as we age. Young people, say a young athlete, is more at risk of herniating out at what we call an acute or a hot disc herniation, and as you get a little bit older, you're more at risk of things like degenerative disc disease or just discs that don't support the spine enough to provide their symptomatic relief. So the pain profile is typically a little bit different. It's a little more indolent, takes more time to sort of develop, and the treatment strategy can be different as well.
Now, you mentioned an athlete. That kind of new to me. Is it due to compression, or what causes it?
I think it's just due to the forces we put through our body. Say if somebody has to quickly turn or pivot or jump or things like that, it's just a result of all of those activities our body undergoes that, sometimes our body just doesn't work the way we want it to.
Yeah, isn't that the truth?
Mm-hmm.
So tell me, what are some symptoms that it might be a herniated disc just versus a muscle strain?
Sure. Most of the time, if you have pain that feels as though it starts either in your neck or your low back, and then it travels and you feel as though you can feel it traveling, say, from your back down one of your legs, very commonly that's a result of a disc pushing against a nerve, versus if it really stays localized to the low back and it feels like a muscle's really tight and knotted up, more often that's something like a muscle strain. So anytime you've got pain that travels to one of your extremities, your arms or your legs, you might be thinking about a disc.
So that is not, what am I trying to say? When the disc sets on the nerve, that nerve kind of gives you a zinger down your arm or your leg.
It's actually one of the most common ways patients describe it to me. They say, "Doc, I got a zinger going down my leg," and we typically can figure out what that is.
All right. So more people, young, old, in terms of disc, or is it just across the board?
It's across the board, fortunately or unfortunately, depending on how you look at it. The discs are incredibly important, and they can cause us problems at various times of our life, and it's my job to help you parse through where you may fall on that spectrum.
Okay, now, you mentioned neck, arms, back, legs. There's different areas in the spine where you may see a disc herniate.
Yes. Most commonly, you'll see this in either your cervical spine, which is your neck, or your lumbar spine, your low back. Rarely and in different instances, you can see it in the middle portion of your back and your thoracic spine, but because your thoracic spine or your mid-back is supported by your rib cage, it's far less mobile, and therefore the discs have to do a little bit less in terms of mobility, so they don't herniate as much. The most common places I see them are in the cervical spine and in the lumbar spine, your neck or your low back.
We're talking to Dr. Petersen Fitz, who is an orthopedic surgeon with Bluegrass Orthopedics, and we're talking about herniated discs. We've got a brief little video here that will show why we're talking about a herniated disc. You told us about the disc, and when it pops out, hits on the nerves, and it can occur in the neck and the back. When is it that somebody needs to see their doctor about that?
I think there's a few different reasons you may want to see a spine doctor about that. Number one, first and foremost, if you have any weakness in your arms or legs that is new, as a result you experience this pain and all of a sudden, well, your hand doesn't work quite like it used to, or maybe your foot doesn't raise up off the floor quite as easily, come and see me, because nerve compression can cause some serious issues with weakness, and the sooner it's treated, the better. Other things are if this pain is just severe and it's been going on for a few weeks and it's interfering with your everyday life, come and see me and see what we can do to help.
All right, so I'm there. What are you going to do to me? What's the process?
So the first thing is we take a very thorough history. We figure out where it's most likely coming from. As a result of that, we will obtain some x-rays there in the office and see if we see anything obviously wrong with the bony anatomy and how the alignment of the spine is. 9 times out of 10, we are going to get an MRI of either your neck or your low back, as long as you can medically tolerate an MRI. And then we'll go through the results of that, and I'll show you exactly where the disc is herniated out and pushing on which nerve.
Okay, so we've got a herniated disc. Well, maybe I should say the treatment options, but do you do stuff before you get to the MRI, or is by the time somebody ends up at your office, they're going to get an MRI?
Most often, although it does go both ways. If this is a painful issue that's relatively new, we do start with a course of physical therapy. We may recommend some things like activity modifications, lifestyle modifications, over-the-counter medications, simple things to try to get you feeling better. And if we can, we don't need to get the MRI. However, if the pain persists, or certainly if we see that weakness, we're going to get the scan.
Now, you mentioned medications. Are there certain types that may help?
As long as you can medically tolerate them, I think anti-inflammatories are some of the best at dealing with this. We know about the disc as they herniate. It does cause a very significant inflammatory response in the spinal canal. So things like Motrin, ibuprofen, or even prescription medications like meloxicam can be very useful getting out of that pain.
Are steroids helpful? I know that's kind of a question.
Again, steroids are wonderful, but they do come with a significant side effect profile. So we take every single case individualized, and if somebody can tolerate the tapered approach of a steroid pack, I think they can be a really powerful tool to use. But if somebody, say, has poorly controlled diabetes or difficult to control diabetes, I probably wouldn't recommend an oral steroid because the risks just don't outweigh the reward.
Okay, so you've got bad leg, bad arm, you come see you get an MRI, they've got a herniated disc, they fail conservative treatment. Operation is an option?
It's an option. I still keep it as a last option. Very often we will try some targeted sort of injections in the lumbar spine, again with a steroid, so if a patient can tolerate it, we do it under x-ray guidance so we know the needle's going in the right spot. We're treating the area of the compressed nerve. If all else fails, there is surgery that can manage this, and typically it can be done as an outpatient, sort of a small operation, minimal recovery time, usually about 2 weeks for an incision to heal, and after about a month, people are usually back to living their normal life.
So what the surgery, you go in and take the disc out, cut the disc away? What's the process?
The process is I identify, again on intraoperative x-ray, which disc has been herniated. I take a little bit of pressure off of the nerve that's been herniated. I scoot that nerve off to the side. I can usually visualize the piece of the disc that's pushing up against it. We remove that piece of the disc. I take a small probe and I feel around, make sure the rest of the disc feels healthy, and that's it. I'm going to close you up.
Get this clear. You said outpatient, go home the same day.
Yes, sir.
Well, that sounds pretty good. All right, let's talk about one thing. You also mentioned outpatient. I was asking you before we came on here about kyphoplasty. Now that's for a crushed vertebrae, which is different than a disc.
Yes.
Tell us what a compression fracture is and what a kyphoplasty is.
Sure. Compression fracture most commonly occurs in the lumbar spine or the lower thoracic spine, and it happens when the bone gets a little bit weak. Maybe you take a hard step off a curb, maybe you have a fall, and the bone just compresses. So it no longer is shaped like a nice brick, it's more shaped like a wedge. And when that happens, it's quite painful. What a kyphoplasty aims to do is we very minimally invasively introduce a small balloon into the vertebral body that's been compressed. We inflate the balloon to create some space, and we backfill it with cement to give it some of that stability back. And again, this is something that at Bluegrass Orthopedics we do as an outpatient whenever possible. We can even do it in our office, so it's an easy in and out day for our patients.
Makes a big difference in their pain, too.
It does. It's one of the most reliable things we're able to offer our patients with compression fractures. Some of our happiest patients come back a week after and say, I wish I could have done that sooner.
Well, thanks for coming in. Thanks for the information, and thanks for all you do for your patients.
Thanks for having me.
And if you have back pain, Dr. Petersen Fitz can help. We'll be right back.